Sure, that'll be great.
Okay. Well, good evening, everybody. I'm deeply honored to have the opportunity to introduce Rick Pollack, class of 1977. I do have some formal remarks and then some informal remarks. So as many of you know, Rick is president and CEO of the American Hospital Association. And Rick is considered one of the nation's leaders in obviously the largest and most influential hospital association. He's been a respected voice in providing health care for the elderly, for children, for low-income families and individuals, for veterans, and for residents of underserved rural and urban areas. Interestingly, Modern Healthcare, a very respected magazine, has regularly named him to its annual list of the 100 most influential people in healthcare, an honor that's also shared with President Barack Obama, Supreme Court Justice Anthony Kennedy, and leaders some of the largest corporations in America. As you know, when Rick left Cortland, he had majored in political science and had a minor in speech communications. And this is not well known, but he actually left for the Hill and he worked for Congressman David Obey of Wisconsin. I do remember Rick telling me that he met his wife on the Hill at that time. He remained in Washington, also received a master's from American University in public administration. And shortly thereafter, he started as a lobbyist for the American Nursing Association. In 1982, now some 38 years ago, he joined the American Hospital Association as the Associate Director for Legislative Affairs. And as you know, they represent some 5,000 hospitals, healthcare systems throughout the United States. So it's been a long career. He is really the primary voice of the association before Congress and the executive branch. And interestingly, not too long ago, I just happened to turn CNN on, and there was Rick with the President of the United States in the Rose Garden talking about PPE and ventilators, really representing the nation. Many of his strategies and positions on healthcare were incorporated into putting people first. This was a policy blueprint used by President Bill Clinton and Vice President Al Gore back in 1992. And because of that, he has since been recognized as an advocate for the landmark Affordable Care Act, which has provided health care for approximately over 16 million uninsured Americans, and now they have coverage. He is described as a brilliant strategist. He has created coalitions of different interests to develop the HAA's Ebola strategy, their plans for veteran care in civilian hospitals, and other initiatives. And he's created a special advisory committee to improve hospital care for minorities and a coalition of national, state, and local hospital groups to ensure adequate government reimbursement for hospital health care. Many of you wouldn't know this, but in 2016, the college and Suny as a system honored Rick with an honorary degree. And it states on his diploma, Rick's entire career reflects SUNY Cortland's core value of promoting the health and well-being of individuals and the community. Thanks to his unparalleled leadership, tireless advocacy, and insightful vision, the lives of millions of people have been changed for the better. But I need to go a little bit further, and let me just share briefly that he is one of the nicest people you could meet and the kindest and gracious individuals. So I hope in the future you get to meet him. And just one little anecdote. So Rick shared with me when he first came to Cortland, he came up against a professor who wasn't the nicest person. And Rick actually thought of maybe leaving Cortland, but others dissuaded him and he continued and of course graduated. And when he was going to get his honorary degree, he asked me if it was possible, if this individual was still alive, and he was, if they could join him, if he could join his family for lunch. And so I called the faculty member and I explained what he had done, but that it set Rick in a completely different direction in life. And he realized that because of that, he was where he was today because of this individual. And so he did join the Pollak family for lunch. I'm not sure, I wasn't at the table, but I would have liked to have been a fly on the wall to hear that conversation. But it's just indicative of the kind of man Rick Pollack is. So Rick, we're delighted that you could be with us here tonight.
Hey, thank you, President Birnbaum. Thank you all for inviting me to be with you this evening. I'm so proud to be a graduate of Cortland State, and my hope for all the students is that it provides all of you with the same kind of academic grounding and practical experience that gives you the opportunity that it provided me. Of course, the other reason I'm glad to be here tonight is that I get to be with President Birnbaum, and I'll do anything he asks me on behalf of the college. He's provided just wonderful leadership. He's transformed the campus. He's established various innovative programs. He's encouraged voluntary community service. And, at a time in our country when we've seen racial and cultural tensions, he's not only assured that there's a safe and learning environment, but he's been a champion for diversity and inclusion. He really cares about the students. If you walk around the campus with him, you can just see the pride that he has in every student and in the school. I also want to welcome Bob Bookman. Rob Bookman, I guess is your name now. Used to be Bob for me. He's a member of the College Foundations Board who's here with us this evening, but more importantly, he's a very dear friend. Not only did we go to college together, but we went to high school together, and I consider him a political mentor. We worked closely together in student government. We worked on the high school newspaper that we were on, and Bob, I'm still going to call you Bob. Bob, if President Birnbaum was around when we were students, I think we would have had a very different relationship with the administration.
That's for sure.
And, Bob is another proud Cortland graduate who's an accomplished attorney and also has served in public service roles for the city of New York. And, the story that President Birnbaum, if I can just elaborate it, I was a political science major. Bob was a history major. One of his favorite professors was Frank Burdick. A very distinguished professor of history. He was the guy that told me as my academic counselor when he looked at my SAT scores that I would never amount to anything. And that just made me prove that he would be wrong. And that's what Eric was referring to earlier. Anyway, I'd be glad to answer any questions that I can. I know we want to have a dialogue rather than me giving a talk.
Yes, that's correct. So thank you, Rick. We're excited that you're able to join us. I'm delighted to be able to have this conversation with you. And I thought it would be good if we start off with, you graduated in '77 and you landed in DC. So tell us a little bit about your journey.
Yeah,
from
and
Portland to DC.
And the interesting thing about it is I never took a health course while I was in Cortland. Back then, they didn't even have health management or health policy courses. It was really health education, very widely recognized for its health education courses, but I never took any of those. And I was a political science major. There was something called the Suny Washington Semester Program. It still exists. It's 53 years old. It's actually run out of Brockport, but they took students from various campuses, and I was selected to kind of represent Cortland. And I was an intern in a congressional office for a semester for David Obey of Wisconsin. At the time, he was a young congressman in his 30s. He ultimately rose to be the chairman of the House Appropriations Committee, but he hired me after the internship. And as President Birnbaum said, I met my wife in his office. We overlapped for about 2 weeks, and the rest is kind of history. So that's how I got down to Washington.
So students, did you hear, in addition to his great education he received at Cortland, his internship, that was kind of, the foundation that then led into him getting the job and transitioning into the workforce and where he is today.
And I might add, in terms of internships, they're incredibly valuable. When I was at Cortland State, I did 2 internships locally, one with the county planning department, one with the district attorney's office. And that combined with my involvement with Bob in student government probably was as important an experience as anything in terms of preparing me for the real world.
That's awesome. So Let's talk about your career a little bit. It's been focused on healthcare and advocacy, government relations. So why does government relations and advocacy play such an integral role in healthcare and healthcare delivery?
Well, if you think about it in terms of healthcare overall and hospitals, just think about it in terms of hospitals. The average hospital in this country gets over 40% of their revenue or volume from Medicare and Medicaid combined. And there are probably 25% of the hospitals in the country that are 75% in terms of the revenue stream that they get from Medicare and Medicaid, Medicare for the elderly, Medicaid for low income, poor, and disabled people. That in and of itself makes you needing to be involved with government. And then I think it's fair to say that the healthcare field is probably one of the most regulated fields of any field in the country when it comes to quality, when it comes to safety, and at multiple levels of government, state, local, and national. So advocacy is so important because government plays such an integral role in the financing, the delivery, the oversight of the healthcare system.
And part of that advocacy piece, you were very integral in passing the ACA legislation. So can you talk a little bit about that, and then also talk about what is your current take on our current healthcare reform debate? We talk about ACA efforts, we talk about repeal and replace. So what is the likelihood that will happen, and what impact that will have on patients? I know that was kind of a lot there, but if you can touch on those areas.
Sure. I'll try to break it down, and I don't want to overstate my involvement in the ACA. There were a lot of people and a lot of organizations that certainly were partners in doing that. But, we obviously were involved. We supported it. We tried to shape it. And we've defended it before the courts twice, and we're in round 3 as we speak. We've defended it from being attacked on various counts. We thought that among the reforms that were included in there as it relates to improving the delivery system, the most important thing was it extended coverage for millions and millions of Americans. And as you well know, the protections for pre-existing conditions, along with keeping kids on the health insurance of their parents until they're 26. You can go down the list of all the things that we think were very important about the ACA. If you look at the political debate right now over healthcare in this country, what you find, and I'll paint it this way, on the right side of the political spectrum, and I'm talking about conservatives and Republicans, they're not that concerned about coverage. They're more concerned about cost. And their view of the world is that if you give people choice to make decisions about their health care by being transparent about price and being transparent about quality, you will incent people to be smarter shoppers when it comes to shopping around for their health care. And that's their kind of view of the world. Now, that's not one, frankly, that I subscribe to. I don't know about you, but if I'm in the back of an ambulance, I'm not going to be shopping around for what the best price is. And in reality, it really is what your out-of-pocket exposure is, as opposed to what your insurance company negotiated with a price with a provider. But that's their view of the world. On the left side of the political spectrum, what you have seen is Medicare for all, kind of Bernie Sanders style, where Medicare would be a part of the whole system, which frankly is problematic to us as well. Because Medicare and Medicaid, those two big government programs that comprise a huge amount of our revenue, pays us less than cost. So it would be very hard mathematically to make that happen. So that's why we embrace the Affordable Care Act, because it comes right down the middle. And it has a public-private partnership, an employer mandate for coverage, a whole series of delivery system reforms that promote coordinated care and move us away from the fee-for-service system that we have today. And we think that we ought to continue to build on it and improve it. And that kind of is the position, frankly, that Vice President Biden basically has, although he would move toward a public program for certain populations. The key that is also important here and is embedded in the Affordable Care Act is moving away from today's fee-for-service system. If we ever want to get a handle on cost in this country, we have to move towards systems that have the right incentives. Under the fee-for-service program that most of you are familiar with, unless you're in a HMO or like Kaiser, who's one of our big members, basically it's volume driven. So for a provider, the incentive is to do more. And there is no incentive to coordinate care. And we think that we need to move toward these new types of systems that provide the right incentives. And that's ultimately the way to improve care and lower costs. And that's a part of the ACA, and that's why we supported it.
So building on the ACA really so that it's patient-centered focus and public and private working together to improve cost. My apologies to...
A quick question on that.
Yeah.
Anytime you listen to Rick, you always learn something. So the administration is in Supreme Court now trying to challenge the Affordable Care Act, but they keep claiming, the vice president in the debate last night keeps claiming that they would still, even if they're successful and the Affordable Care Act was thrown out, they would still be able to have a system which still guaranteed the two things that everybody loves, which is coverage for pre-existing conditions and keeping your kids till age 26 under policy. How would that possibly be affordable for the hospitals and the doctors without the rest of all this public partnership that you just described?
Well, it's a great question, and it's a very integral system that we have here, and essentially throwing out all the other pieces, but saying we're going to retain a ban on pre-existing conditions and that we're going to keep kids on, it unravels the intricacies of what was built here. Because the whole issue here is trying to get as many people covered as possible. And for the insurance companies to be viable, if you have a public-private system, you have to have as many people in the pool. And you can't discriminate against people with pre-existing conditions. The real point here, and you might have seen the president announce about 2 weeks ago, and Republicans continue to say it, we're for pre-existing conditions, we're for protecting all of that, but they want to throw out the law in the courts. Well, if they're for that, you need to pass a law to do it. And the president issued an executive order like 2 weeks ago, and he said it's the policy of the United States that we will protect pre-existing conditions. That is meaningless. You have to have a statute, you're the lawyer, to actually say that it exists. So executive orders are meaningless. And again, to the underlying point, you cannot just mandate those things without having these other elements in place to make the system work. I think you're on mute.
My apologies. Thank you. Thanks, Rob. Great question. And for the audience, I forgot to say at the start, as we continue this conversation, please type your questions in the chat. And towards the end, we'll have a discussion in terms of questions from the students and questions also from the audience. So we're going to switch gears a little bit and talk about COVID. So we're at over 200,000 deaths, 7.5 million cases. And we've seen some amazing work from our frontline and healthcare workers, and some of whom we've also sadly lost. We'll start off with Rick. What do you think are some of the challenges the hospitals and the health systems faced early on, and how did we address them? Or are there still things we need to address as well?
Early on, if you want to go back to the beginning, the biggest challenge we faced was that the administration didn't face up to the fact that we had a problem. And one can argue that that still is the case. And the fact that we had to constantly educate them about the fact that we've got a big problem here that needs a national response. Back in March, we were calling for the declaration of an emergency a national emergency, along with the American Medical Association, the American Nurses Association, just to unleash all of the flexibilities that were needed to respond. So the biggest challenge from the get-go was providing people with a reality check as to what was going on the ground. And I got to say, that continues to go on. You know, we continue to say or hear people say that testing is widely available. Well, it really isn't in many parts of the country. It's very uneven. The framework that we have taken in dealing with the challenge around COVID are what I call the 3 R's. First is relief. We had to provide relief to all providers because remember, there were 2 to 3 months when everything was shut down. We weren't allowed to do any kind of elective procedures. That meant that all of the revenue from elective procedures dried up for nearly 2 to 3 months for all providers. Now, keep in mind, elective procedures is not just cosmetic surgery and knees and hips. You could stop doing those. That's legitimate. But a lot of elective surgery means it's scheduled. And scheduled procedures are life-saving. It might be diagnosing a tumor. It may be replacing a heart valve. These are not inconsequential things. But the fact of the matter is that for 2 to 3 months, that was all shut down. It created a severe financial problem. The other part, of course, was preparing and caring for COVID patients. COVID patients, when they're in hospitals on ventilators, are require very, very sophisticated care and require a very, very high staff to patient ratio. So that was expensive. Setting up alternative sites of care, that was very expensive. We engaged in, in New York, in battlefield medicine in Central Park. I mean, all of that is very expensive. So the first R for COVID was relief. And that came in the form of money, over $175 billion through emergency funds. And it came in the form of regulatory waivers that allowed our folks to act in a quick and decisive manner. And one of the big ones had to do with telehealth. Telehealth, which actually became very important, was very restrictive in terms of the kinds of services and the places that it could be used. It was only really available in rural areas. We needed to get a lot of waivers. So that was the relief portion. That's the first R. The second R is recovery in our framework. And that's a challenge too, because the challenge that hospitals face now is that we're in what I would call a patchwork pandemic. It pops up in different parts of the country at different times with different intensity. And every hospital in the country now has to be COVID ready for any emergency, but at the same time, they have to be COVID safe to take care of regular services, those sort of elective services, if you will, that are very important, not only to keep people healthy, but to stay financially viable. So this recovery period of being COVID ready and COVID safe is something that is very detailed, involves a lot of work, and is the second R. And then the third R is more long-term, and it's rebuilding. Because as we go through this experience, we need to learn from it. There are certain things that we need to reboot that we stopped. There are certain things that we need to reevaluate as to whether they should continue the way we used to do them. And then we need to reimagine. We need to take this experience and try to create a better healthcare system from the future, from the learnings that we got, the learnings with telehealth, the learnings for having a supply chain that just rely on China, that's more diversified. There are a lot of learnings here. Now, in addition to these 3 R's, the other framework that we operate under is what I call the big 3. And there were 3 big challenges to our healthcare system before COVID, BC. One was the issue of workforce resiliency. We have a burnout problem for a lot of our frontline workers that just got exacerbated. The second big issue we've had is behavioral health. Over 20% of the people in the country have some form of a behavioral health condition. It varies from very minor to some more acute, but that's a significant number of people, and we don't have nearly enough providers to take care of them. And then the third R is health equity and disparities, because we've seen, we knew that we had these issues, but COVID made it even more acute. And I think there's a greater awareness. So we got the 3 R's and the big 3, and that's kind of the framework that captures the challenges and the strategy that we have going forward.
And how do you think are some ways that we can address some of those challenges? Let's start with workforce burnout, nurses and physicians, especially the frontline clinicians.
Yeah, it's so very important because to state the obvious, they have truly been the healthcare heroes. Whether it's the doctors, the nurses, the respiratory therapists, the people that clean the rooms and bring the food. And there are a lot of things that we need to do to support those folks. The most basic one is making sure that personal protective equipment is available. And the stockpiles that now exist that didn't exist at the beginning of this, is very different. Housing for people that may work in COVID units that don't want to go home, making sure that that housing is available to them. Bonus pay for frontline workers. That's very important. Making sure that there's childcare that is subsidized or available for frontline workers so that they're able to come to work, to be the heroes that they are. There's a whole long list of things like that that we need to do to be as supportive as we can. And I might say that many of those provisions are actually exist in the House passed what we call CARES 4.0. There have been 3 big legislative packages to address this issue. The 4th one is now being argued over between the politicians. The House passed one version of it called the Heroes Bill, and it actually includes a lot of these provisions that I just mentioned that help frontline workers.
And what about addressing some of the health equity and disparities?
Yeah, and that was an issue that obviously existed and exists before COVID, and it just created a greater awareness. Now, a lot of that is because we find that a lot of essential workers that contracted COVID didn't have the luxury of working from home over that period of time, and they were more susceptible to being in that situation. A lot of folks that are in those categories, if you will, had many underlying conditions that may have been a result of not being insured, not getting coverage, or unconscious bias that exists in the healthcare system. So all of these need to be addressed. The first step in addressing it is obviously data. And we've asked the government to collect the necessary data. Data really shows you where the problem is and how to correct for it. And it's really important that you have the data so that the testing supplies and the testing mechanisms can go to the communities that need it. It's really important that when a vaccine comes down, that those people are priorities for getting the vaccine. So it's those kinds of things that we need to do. Now, beyond that, there are more institutional efforts that we're undertaking to address the issue of health disparities. We have a partnership with the National Urban League and Unidos US to get at the issue of moms and babies. The number of the mortality rate for Black women in particular, and also Latino and Hispanic women, is sky high. It's ridiculous, and we have to get our arms around that. And we're working with those 2 organizations in an effort to sensitize people to it. And keep in mind that a third of the deaths or the problems with maternal mortality occur outside the hospital before they even come in. A third occur in the hospital, and a third occur after they leave the hospital. Now, we're obviously accountable for what goes on in our buildings, and there's no excuse for any of that, and we need to do better. But there's 2/3 of it that occur because of what we call the socioeconomic factors of health that are not getting the right prenatal care and not getting the right post-discharge care. So all of this is a priority for us, and we've got to do better. And, the greater awareness that we've seen around social justice inequities and health inequities that has been a result of all of the events of the past summer, we can't just let this moment in time pass. We really need to make sure that this awareness results in action. We got to stop talking about it and start doing things about it.
Thank you. Those were some definitely great points made. I know with infant mortality and maternal mortality rates, I remember when I did a paper on it a couple of years ago, and I was just, really shocked in terms of African-American women at the rate that they were in comparison to white females in the 80s. They were now catching up to that. So almost a 30-year gap. And that's still something that's struggled with when you even look at, you control for socioeconomic status and everything else. And the rates are still, there's that gap that still exists.
And Professor, you make a really important point there. When you look at, when you control for income and educational level, there is no difference.
There's no difference. And I remember reading a paper in terms of they measured immigrants. So first generation, the rates were similar to that of whites, but then by second generation, it was the same for African Americans. So, it's tied to systematic racism and the oppression piece. So it's definitely an area that one of the areas we struggle with in the healthcare system. And then you touched on telemedicine a piece. So in terms of telemedicine, telehealth, we had to get waivers for that. How do you think that will affect hospitals and health systems plans in the future in terms of, will we be seeing more healthcare practitioners or employees working from home and an increase in that? What are your thoughts on that?
Yeah, the telehealth genie is out of the bottle as a result of this experience. We won't go back. It's created a whole new world. And let's face it, our millennials prefer to. They never want to go into an institution or a doctor's office. They'd rather do it that way. So the cat's out of the bag on that one. But I think there's a larger issue here. And the story to this is that we've been really trying to redefine ourselves as hospitals. Hospitals are often thought of as buildings. And when you see that H on the road sign, it's iconic in the sense that, it signals a place of safety. It signals a place of security. You're going to get taken care of. And, the buildings will still exist for emergency, for trauma. They'll exist for sophisticated surgery, they'll exist for sophisticated diagnostics. But the fact of the matter is a lot of care can be done outside the hospital. And whether it's through telehealth or whether it is through home care or whether it is through clinics that are community-based, I think we're going to see a big movement. What I've said to our membership is we have to redefine the H. It's great that it's viewed as a building, but it needs to be viewed as a network of caring. And I think among providers now, there's a race to provide care in the home. And I think we're going to go back to house calls for doctors. I think we're going to, see a different system. This was all put in motion in a significant way, but then COVID hit and it changed. And again, we were the indispensable trusted partner when it came to emergencies with COVID. But at the same time, there was a need to take care of people outside the hospital. Part of what we needed to do is to keep people out of it that weren't really sick. And that meant providing care in the home. That meant providing care in alternative sites. Now, I don't think, obviously you see CVS and you see Walmart and you see a lot of these other players trying to get into the healthcare ecosystem, as we call it. I don't think they're going to be delivering babies or doing MRIs in the CVS. And when you have an emergency, I don't think you're going to go to the strip mall. But I do think we do have to redefine ourselves. And that's been one of my missions, if you will, for our members, is to get them to redefine themselves. When it comes to the issue of quality, everybody assumes you're going to get quality. And I think we have made fantastic improvements in quality. But from a consumer perspective, what people really want, and I can say it as a consumer, it's all about convenience. And, a lot of our hospitals are not the most convenient places to navigate. So we're trying to redefine that H, keep the good parts and try to make the rest of it more contemporary in terms of the way we deliver care.
And speaking of telehealth, I see increasing access in certain areas, but then also maybe decreasing it in those who may be able to afford having, the systems for it. So what do you say to that population that may not necessarily be able to utilize telehealth services, or do we use the current system to still make sure it's accessible for them?
Yep, that's one of the drawbacks of telehealth is that not everybody has access to broadband. And, it could be, low-income communities in urban areas, but there are vast swatches of this country in rural and frontier areas that are broadband deserts that simply don't have that access. Now, that HEROES bill I mentioned before that passed the House includes billions of dollars to ensure that broadband is more available in a lot of communities that don't have it. Now, telehealth, again, is not the answer to everything, but it has a lot of potential. One of the big areas that it has potential is in behavioral health, because there are a lot of rural communities in this country that just don't have access to psychiatrists or psychologists. Telehealth is part of the answer. And given the stigma, the way seeking mental health care or behavioral health care has a stigma to it, telehealth is a way to deal with that to some degree. So that piece that you mentioned, Professor, about the need to have broadband more available to maximize access through telehealth is one that we as a country need to address.
And thank you for bringing up that rural health piece. That's something I probably should have mentioned when we talked about the impact of COVID on the rural health population in terms of rural hospitals, in terms of, you talked about hospitals closing and not being able to do additional services. What impact do you think that'll have on rural hospitals? Are we going to see those declining, or what are your thoughts on that?
Yeah,
How do we further support to make sure that they're not closing? That's my question.
Well, half the rural hospitals in the country are attached to larger healthcare systems, so they kind of have a lifeline, if you will, and they have referral patterns and they have support. The other half is kind of out on their own, and that's the half that we need to worry about. And they too need to redefine the H, if you will. And that's very difficult for a lot of rural communities because often the hospital is the largest employer in a community and nobody wants to change what they have. But the reality is that rural hospitals probably need to stop trying to be everything to everybody. And they need to focus on areas where they can be most useful, meaning urgent care, ambulatory surgery, having the ability to get people to more sophisticated places that can provide the more intensive care that's necessary. They need to be access points and anchors in communities, but they may not need to be full service everything the way all of them have been in the past. Again, networks of caring. It may be that rather than having a 50-bed hospital or a 25-bed hospital, that they need to be, an urgent care type setting with an emergency room and an ambulatory surgery center connected to it, and maybe a skilled nursing center connected to it. Again, a network of caring. Now, every community is different. Every needs are different. But rural hospitals need to redefine themselves as well. Right now, 1,400 of the 5,000 hospitals in this country are rural or frontier. Of those 1,400, they have 25 beds or less. And they are like the police station and the fire station. They're the only access point. So you need to support them to be an access point and an anchor. It's just a question of what shape they have. There is a bill that's before Congress right now called the Rural Emergency Medical Center Act, and that would give hospitals to transform themselves in the way I just described. So there is change that needs to be looked at. But again, 20% of all Americans live in rural areas, and you got to provide access to essential services there, but there are new configurations that need to be looked at.
Okay, thank you. We're gonna, you mentioned something, you tied in rural health, and then you also talked about behavioral health. So I wanna go back to behavioral health for a little bit. And, you know, prior to COVID, we did start seeing increase a little in terms of focus more on behavioral health with the opioid epidemic, with HIV as well. How do you see us integrating it more into primary care? You mentioned a lot of times the stigma associated with it, and you know it's seen as separate. Sometimes it's the criminal justice focus or the social, and not really focusing on the medical aspect. So what do we really need to do to make sure that's integrated more?
Well, there are a couple of things. You know, the first thing is, you know, back in 2008, Paul Wellstone and Pete Domenici, senator from Minnesota and senator from New Mexico, passed into law something called the Mental Health Parity Act. And that basically said that insurance companies needed to cover mental health conditions, including substance abuse, in the same way they provided benefits for physical health services. And unfortunately, the insurance companies have cut a lot of corners in how they try to comply, or I should say not comply with that law. And that's been a real problem. And there's legislation that's been introduced to try to crack down on that, to truly provide equity in coverage and benefits for physical and mental health benefits. But the key point you made, Professor, is the most important. And it really is integrating mental health care and physical health care. And one of the things that we really need to do, and it's going to take a long time, is to start to educate primary care providers to be more proficient in taking care of mental health conditions, whether it's the nurses or whether it's the primary care doctors that, you know, don't have the competencies and never received it in their training to be the frontline mental health provider. You know, again, when you don't have enough psychologists and psychologists, you need reinforcement on the front end for detection and for channeling and for handling the more minor behavioral health issues. And we've been working with the medical schools and the nursing schools to really change the way education works so that we can be more effective in that regard. We'll never have enough clinical behavioral health professionals to take care of the scope of the problem that we have out there. And the other thing we tell people is the last thing you should do is put the sign mental health department on the building. I mean, that just creates the kind of stigma that is not necessary for people that are seeking that kind of care.
So I worked at a behavioral health agency 2007 to 2014. So even when you mentioned the Parity bill in 2010, we often had difficulty with that, with insurances actually reimbursing us for services or even limiting the services. Like you'll receive substance use treatment for 30 days and limited into that. And I'm happy to hear there's a bill in place to ensure that the loopholes there's not loopholes that can be passed, and making that great point as well in terms of focusing on the education and the training and the competencies for mental health, and making sure, I think also that the tying back to patient-centered care, like you said, if there's a referral that needs to be made and incorporating that piece.
Yeah, just as an example, you know, the insurance companies, you know, they'll say they're covering the mental health care, but then they won't cover the medicine. You know, that's the kind of stuff, or they'll make it difficult to get the medicines that you need while they'll say they cover the benefits. So that's the kind of games that get played. You know, some familiar names like Representative Joe Kennedy and Elizabeth Warren and Chris Murphy of Connecticut. You know, they're all been very good in working on this and introducing a new version of that Wellstone-Domenici Act.
So what are some of the, any additional pressing issues that you think we are currently facing?
Oh boy, where do I start? Like I said, it's those three right now. When we started this year, and President Binnebaum will appreciate this. Everybody had a strategic plan. Every hospital in this country, our association, but
out the
COVID
door.
was not in our strategic
Went
plan.
out the door.
So we had to redo it to the three R's and the big three. So that's kind of where we're focused right now. We've got a lot of other issues. Listen, affordability in healthcare is a big issue. Dealing with drug costs is a very big issue. Dealing with that is very significant. As much as we support the Affordable Care Act, it's really important to recognize that it still leaves over 23 million people without insurance in this country. I think it's up to 30 million. And we need to further expand coverage. Medicaid got expanded in roughly 35 states. There are 15 states, some of them with a lot of uninsured people like Florida and Texas that still need to expand Medicaid coverage. Right now in that HEROES bill, people that get unemployed during the COVID emergency, we think that we ought to have federal subsidies for COBRA total to cover those unemployed people. So the coverage part is still very troublesome, and we still need to get a handle on that. Again, ACA, was intended to expand it, and it did, but it didn't do the job completely.
It added coverage, but it's still not universal when we think about looking at, other developing countries. And you brought up a great point with the South. Usually when we look at health outcomes, it's usually in regions of the South, and some of those states have not expanded Medicaid. So I think that helps, like you said, with not being able to get access or have coverage for services.
Yeah, and of course, you have the young invincibles that don't feel as if they should have insurance, even though there's a mandate, and they took away the penalty for not having it. And then you have people that slip through the cracks, whether they're, homeless. And then, we have a real problem in terms of immigrants that are not entitled to care because they're not citizens. And, you look at it from our perspective, under federal law, and by virtue of the mission of hospitals, the vast majority of whom are nonprofit and or faith-based, we take care of any human being that walks through the door. They get a screening and life stabilizing care at a minimum. And it doesn't matter who they are. So this issue of coverage to us is one that, it's something that just needs to be addressed.
Okay, and I'm looking in the chat right now, and I see that Dr. Barbara Barton, our healthcare manager coordinator, she put a question in. So I coordinate fieldwork experiences for HCM students here and agree wholeheartedly about the importance of these experiences for students. But because of COVID, getting a placement in a hospital or any health agency at this time is very difficult. Hospital placements are particularly rare. I understand why hospitals are reluctant or declining to take students. The reality is that students are missing out. So in this time of COVID, what advice do you have for students regarding internships? Do you think this will impact their job opportunities? Do you have any suggestions for how students might prepare for the reality of work without the benefit of an in-place internship?
That's an interesting question, and I need to look into that further because it's the first time it's been raised. In fact, just this past week, I was visiting one of our members locally, and when I walked through the door to get screened, for my temperature and all the stuff, basically there were two students that were doing the screening, and frankly, the measures that have been put in place in our hospitals, I think they're safer to go to for care than going to the grocery store when you think about the screenings that take place and the precautions that are in place. So that's the first I've heard about there being problems in terms of students. In fact, one of the things that occurred during the height of the pandemic in New York and in other places, it happened in Arizona, Texas, Florida, and other places when there were spikes, is that medical students that were in their last year of training were permitted to do things that perhaps they would not have ordinarily been allowed to do. Same thing for nursing students, because we needed all the manpower and women power possible. So I need to look into that to see where there might be problems on an institutional level, because right now one of the challenges that we face is convincing people that it's safe to come back for care. A lot of people are reluctant to come to hospitals because they think they'll get infected, notwithstanding all of the precautions that have been put in place. And I might add that, for hospitals, it's not our first rodeo in dealing with infectious disease. I mean, there are all sorts of standards that are in place relative to how you deal with infectious disease. And while COVID is unprecedented in its nature and scope, it's not as if this is something new that we have to deal with. We've had to take, additional precautions for sure. But I'll have to look into that.
Okay, thank you. Yes, because we have had hospital, especially for our healthcare management students, like Dr. Barton shared, we have had hospitals initially had interest, but then once COVID hit, it was like, wait, we'll see. And then from the summer, it was no. So we're looking at virtual options, but for most of our students who are really planning on going into the hospital system in some type of administrative way, whether it was through finance or quality or HR, most of the options are no longer seeming to be available for them.
Well, that's an interesting angle because, not for administrative positions as opposed to clinical positions on the front lines. Not unlike in every other sector, a lot more people are now working from home. Even in our organization, we're only at 25% and we rotate. And a lot of people are working from home, and it's very hard to recruit people for any type of position when you're in a virtual environment. So that becomes a real challenge.
So at this time, I'm going to open it up to questions. So if you do have a question, go ahead and type it in the chat. I did have a number of students send me questions prior, so I'm actually going to start off with that piece. Of course, I lost the page. So Megan Perrine, she's a community health major, said, if you could give your college age self some advice, what would it be?
In college age in general? Well, I go back to my own experience, and my own experience was one, and I think one of the other folks just asked the question, and it's unfortunate in this environment. I think internships are the most important thing that give you a track to a career. It worked for me. It worked for a lot of people that I know. And when we get to the end of this, and we will get to the end of this at some point, and things will get to be normal, I really would stress internships. Of course, it's always great to get credit for it, but voluntary ones as well will give you a leg up in terms of understanding the real world and applying your academic skills.
And you just,
Rick, could I ask, a follow-up to that student's wonderful question? If you were this 18-year-old, what coursework or, reading, speaking, writing, what would you tell yourself that, I'm going to need these additional skills? What would you share with our students? I thought it was a great question, and I'm curious, looking back, you run a major organization in this country. What would have been helpful?
Well, it's a funny question, because I'm almost tempted to say I'm the wrong guy to ask, because I never took a health course in my life. When I worked on Capitol Hill, I did education and labor issues and didn't do any health issues, and here I am. Now, the part of that journey is that I worked on the Appropriations Committee, and I knew the process for getting money. And the American Nurses Association, who I was a lobbyist for initially, said, your job is to get us money for nurse training programs. So I'm not the best to answer that question. However, as an employer, a significant employer, I got to tell you, I think the most important thing, and I see it lacking everywhere now, is communication skills and basic writing. That is so important to any career track. And I see the young people, because of the reliance on social media these days, they don't write real well. And I think, basic writing skills, basic communication skills are so important to any career. And I see that lacking now. And I think that's one thing to really focus on. The stuff they give me, I have to edit, I can't believe.
I think that's something all faculty on this call could agree with, that it's something we're aware of and we're working on. I teach a writing intensive course, and yes, that's definitely something that we're working on. I see a question in the chat from Rick. Please explain how your student government experience and advocacy helped in your career. Because you kind of mentioned, following up on Eric's question, where yes, you may not have taken a health class, but you really talked about, the opportunities, and from your journey, each opportunity actually got to where you're at. So talk about that aspect.
Well, I want to invite Rob Bookman into this one, because he was my mentor in this one, and he got me involved in student government at Cortland, and he was 1 year ahead of me, and he was a big shot at the time, and he got me involved. And it's really, politics is local, and whether it's student government or whether it is national government or state government, politics is the art of bringing people together, finding consensus. It's sometimes the politics of dividing up resources. I mean, we spent many nights in budget hearings for the fees that were collected for the student programs. That was the most practical experience early on. Bob, you must have something to say about that.
Well, I wanted you to, because it's just such a pleasure listening to you and hearing you. No, seriously, it's there's a Yiddish word, kvelling, it means that you're so filled with pride. And listening to you, and how much information you have, through the foundation board, I've had the privilege of getting to know a lot of the college students in the last couple of years, and I got to tell you, they're much smarter and more serious than we are, and they're much more focused, than we were. I'm not even sure we could get into Cortland today, but they, listening to you, one would think that you came from a privileged background with private schools, and yet the truth of the matter is we grew up in very modest middle-class neighborhood in Brooklyn, in apartments with sharing bedrooms, and both of us are product of public schools from the beginning through the end. But I do think our student government experience was key in giving us many experiences which set us on our lives, a legal career for me and an advocacy career, for Rick. And he's right, whether it's student government or being on the student representatives on the faculty senate, this course teachers evaluations that we did, we had to negotiate to get the administration to agree to all of those things, are valuable experiences. And you can wind up being one of the most important. And the message I want to say to the kids, you could wind up being one of the most important people in the health field in the United States today without ever have taken a health course. But the skills that Rick brings to this job and has successfully brought throughout his career are learned in a variety of different ways. So be open to all of that. Be involved in things like student government and in advocacy, because you never know what skills you're going to learn and how it's going to help you.
Well stated.
Awesome. Dr. Blavos was giving her thumbs up, as she always focuses on advocacy. That's one of her passions, and sharing with the students in terms of being involved, adding on to the academic piece to tie into their career experience and further their career experience. So another question here is from Riley Wood. She's a healthcare management major. What kind of advice do you have for healthcare students graduating during this time? You did say that it will get better, it'll pass, but we have students graduating this fall, next spring. So what advice would you have for those students?
And by the way, beyond the writing advice, part of it is, healthcare is such a huge field these days, and there are so many different dimensions to it. And you should always be exploring the different dimensions. There's the information technology where data is king, and the use of algorithms to be able to do diagnostics and to pinpoint, where you need to focus care is a big area into itself. The data scientists, that's an area. The community health people, that's an area. Obviously, the management of the clinical enterprise in a hospital, that's another area. So much of the care, and this is the important point, when you think about healthcare these days, so much of the care is not going to be in the building. It's going to be in different settings. When you think about where most of the resources are going to be consumed in the future, it's going to be on chronic care management of the baby boom. That's where the money is going to be spent. That's where the resources are going to go. That's where the need is going to be going. So when you think about careers, well, I don't want to dissuade you from, the hospital side. Just be open to all of the other healthcare settings that exist. And whether it is the ambulatory care clinics or whether it is the drugstores that are now getting involved in primary care, whether it's the community health centers, whether it's those types of settings. Just think about the broad base of opportunity that's out there. The one thing is healthcare as a field. It's only going to expand, and that's why the opportunity is there. We do need to address the issue of affordability, but healthcare spending, just by virtue of the demographics, is not going to go down. It's only going to go up. The question is how you can restrain the rate of increase, and that means that it will be a vibrant field for years to come.
And then you also touched on a point that we didn't even talk about earlier in terms of the geriatric population. Is the population is aging, the baby boomers, and then chronic illnesses. So in terms of needing more care. So yes, definitely some areas. One of our healthcare management students, Dom Gambetto, how did you decide that you wanted to pursue your current career?
I was drawn to Capitol Hill initially, and actually, if I just step back for a second, and Bob will relate to this, we worked on the student newspaper in high school, and I was a political science major and a communications major, and I was always interested in journalism, but I then sort of switched gears and said, I want to be a player. I don't want to be an observer. And I always thought, well, journalism is something that is very important. Good journalism, real journalism is very important. It's still more of an observer and a critique, if you will. And I wanted to be a player. And that's kind of what brought me in this direction of wanting to contribute. And, you can contribute, obviously, working in the government, working in Congress, but you can also contribute from the outside. And, it's a different way of contributing, but certainly what we do to influence public policy is significant as if, we work on the Hill itself. And, the credibility comes from being a source of objective information that's data driven. It comes from always telling people both sides of the story. It comes from putting together unique coalitions of what we call strange bedfellows. It comes together in terms of how you frame issues. It comes together in how you educate other stakeholders and the media. There are a lot of techniques that you do to influence public policy. I also won't, I'll be candid with you too, and this is an important thing for the political science students. We have one of the largest political action committees in healthcare, and money is also still important I would be a great fan of public financing, frankly. I spend too much money raising money for candidates that share our views, that help us, that deserve our support. But money is a part of the process as well, and you need to participate in that, and that is something that still exists. You hear a lot about PACs, political action committees. And, one of the things that you all should know about political action committees is that was a reform many years ago to replace cash in brown paper bags. Political action committees are highly regulated, highly transparent. There are limits on what you can contribute to any one candidate. And, on the one hand, when you have real rich people that are able to, give enormous contributions, what political action committees do is allow small contributors to pool their resources so you can have a unified voice on a particular issue or a particular field. So I think that that's something to keep in mind when you think about the political side of advocacy.
I remember in our prior conversation, you spoke about that piece as well. So thank you for bringing that up. Another question from a student is, what leadership qualities helped you achieve your position as president and CEO of American Hospital Association? This one's from Maddie Sezelman. She's a healthcare management major.
I think the most important thing in leadership is bringing people along and making sure that they are invested in the product that you're developing. People who have a role in coming up with a solution get invested in it, and then they make it their own. And I think that that's a very important part of leadership. I mean, there are the basics of good communication, integrity, being a role model, and all of that. But investing people in what you do and making them feel a part of it is incredibly important. The other thing, and it's funny, I had this conversation with Bob earlier today, this afternoon we were talking, I was saying, one of my mentors early in my career said, never feel insecure about hiring people that are smarter than you. And I've lived by that. And building teams and never being afraid to have the smartest people around you is something that has been extremely important in terms of providing leadership. It's hard to make a mistake when you have a lot of smart people around you. And I've worked really hard to ensure that the teams that I work with are the best and the brightest.
That's awesome. We actually talk about that in the ethics and policy class when we get to healthcare management leadership, focusing on some of those qualities.
So when you say healthcare ethics, I can't resist saying something here about the current situation that we're in with regard to dealing with COVID. It is very difficult right now when we watch the politicalization of public health and the lack of respect for our scientists and the lack of respect for our clinical experts. From our perspective, we're going to be guided by the experts and the clinical leaders in the science and what we do. And science is going to save us on this one. We just don't know when. But the notion that wearing a mask is something that's a political statement is absurd. And the notion that we would approve vaccines that didn't go through the appropriate process to be a check on safety is really something to be concerned about. And, we, along with several other organizations, have endorsed an approach that's been recommended by the National Academy of Medicine as it relates to, the vaccine approval and distribution process. So this is something that is of great concern as an ethical matter. We really have to all keep an eye on that one and hold our elected officials accountable.
Thank you. I think that point was well said. I think sometimes it's even difficult teaching when you're teaching about primary prevention and secondary prevention, and we see that our leaders aren't adhering to that and the issues that have bubbled up over the last 6 months. What was the hardest obstacle you have encountered in your career?
The hardest obstacle. Oh boy, there've been a lot along the way. I guess the hardest obstacle that I've probably encountered in the role. I guess I'll say two. The first is when I first started in this 38 years ago at AHA, or even longer on Capitol Hill, there wasn't the partisanship that exists today. And, there was a lot more statesmen that were around that looked to achieve consensus in a bipartisan way. And that you don't see that at all today. People don't, compromise for some is a dirty word. People don't want to win. They want to kind of kill the opposition. And for an organization like ours, that is bipartisan and seeks to be solution oriented. And by the way, everything we do, we try to do in a bipartisan way. Any bill that we'll get behind, we try to do in a bipartisan way. This lack of bipartisanship is a real obstacle. And, there are certain organizations that tend to be very partisan. The labor unions are very, very partisan from a Democratic perspective. The Chamber of Commerce tends to be very partisan from a Republican perspective. When you're in the middle like us, it's challenging and it's an obstacle because you're never considered to be on anybody's team. We're kind of independent, and not being on someone's team sometimes is held against you. I could tell you the support that we gave to the Affordable Care Act is something that I have scars on my body, not literally, but figuratively, for having supported that. Republicans will never let us down for having supported the ACA. And here we are 10, 12 years after the fact. So that's been a real obstacle. We've negotiated it through. So while it's an obstacle, we've dealt with it. The other big obstacle in being a trade association or a professional association for a umbrella group is that we have to herd a lot of cats. So if you look at the American Hospital Association, we have 50 state associations that are our partners, but they're parochial about the needs of their state. I understand that. There are 14 other national associations that represent hospitals, the teaching hospitals, the for-profit hospitals, the public hospitals, the psych hospitals, the rehab hospitals. And then you have the rural hospitals, and then you have the inner city hospitals. Trying to have consensus and unity, which is so important for having influence for your field, is a constant obstacle. Now, those are obstacles that we've overcome, and you learn how to do that as much as you can. But I'd be less than candid if I didn't say that sometimes you do have divisions. And, there used to be a saying on Capitol Hill from Senator Russell Long, the legendary senator from Louisiana. Some of my friends are on one side of the issue. Some of my friends are on the other side of the issue. I'm going to stick with my friends. And, sometimes we find ourselves in that position.
So you talked about your challenge, your obstacles and your hurdles. What about what has been something that has been a great motivator for you being in the position that you are?
Well, the big motivator are our members. I mean, they are out there saving lives, performing miracles, and keeping people healthy. A lot of people always say to me, how can you possibly work for a place for 38 years? And, my typical response is, I give a poor interview. But, the reality is that I've been blessed in working for a membership that I truly believe in, that are cornerstones of communities, that are safety nets for communities, and that do really good work. Listen, I could have been a lobbyist and I could have run a trade association for anything. But being able to run and be a part of an association that has a vision and mission that is meaningful and that, advances health in America is something that is very special. And it's been reinforced through the pandemic. A lot of people didn't have the privilege that we've had to help people on the front lines, to make sure they had the PPE, to make sure that they had the ventilators, to make sure that they had the equipment. So it's a real privilege to be able to serve the people that we represent.
Thank you. And that question was from one of our students as well, Samantha Castro. I forgot to say her name at the beginning. So you just talked about serving the members with ventilators, having the PPE. As we're possibly going into our second wave, how are the members feeling? Are we having the equipment now that we need if there's an increase? How is surge capacity looking for the hospital systems?
Well, we're in so much better shape than we were at the beginning. You always learn. I mean, this is a university and it's all about learning, and learning never stops. And we've learned a lot. I think the supply chains are now so much better. The stockpiles are so much better. Testing still has some problems along the way. The biggest problem we have is making sure that staff are not exhausted on the front lines when you get into the surges. That's the one thing that the CEOs of the hospitals are most concerned about as we go into another spike. But we are finding clinically, we've learned a lot. At the very beginning, there was a great dependence of putting people on ventilators. We learned that maybe putting people on ventilators wasn't the first way to go. We've seen certain pharmaceuticals come into play that are now being utilized much better than they were in the past. We see lower rates of hospitalization and ICU care than we saw at the beginning. Now, that doesn't mean that right now Wisconsin has a big problem and that Florida is starting to have a big problem, but in a lot of other places, it's not at that level of intensity. So I think that the clinicians have learned a lot in terms of, how to use different drugs, whether it's ricinimir or whether it is steroids or whether it is certain other drugs that have been given the approval of the FDA. And I think we've made a lot of improvements. So I feel like we're in a better place than we were. But at the same time, we're not at the end of the road here. And I suspect we're not going to be at the end of the road until sometime in the middle of next year. And even when we have a vaccine, it's not going to be easy to get that out. One of the things about the vaccine, and we're working real hard on this, is that for this particular vaccine, there has to be kept under very high refrigeration levels. And Operation Warp Speed in the military, I hope they're getting enough refrigerated trucks because that's going to be a big issue. And for flu vaccines and other vaccines, you can go to your local pharmacy and your local doctor's office. But for this vaccine, you're going to end up having to come to more sophisticated places like us because we have the capacity to do the refrigeration. This vaccine may require 2 shots. So tracking people to make sure, because we're going to have multiple vaccines, that they're being consistent in the vaccine and the information systems are tracking them properly is going to be a challenge. Getting the refrigeration, by the way, to the rural areas is going to be a challenge. And then we'll obviously, assuming that we have a vaccine that's properly tested and determined to be safe, there's also the public education part that it is safe to take it. Because even with the flu shot, there is, and other vaccines, there's the anti-vax community. So on the vaccine issue, there's a lot of pieces to that still need to play out.
Yeah, I think you brought up a good point in terms of the safety of the vaccine and then in terms of anti-vaxxers, but then there's also the trust system in terms of, is it actually safe for us? So number of different factors. Have you ever had a hard time balancing family and friends and your career?
Balancing family and friends, boy, I don't know anybody that doesn't have a hard time balancing friends and family in a career. It's a constant struggle. And, I don't know if you ever get it perfect. Maintaining hobbies and trying to maintain some quality of life, is very, very important for anybody in any career. Not doing that leads to burnout, and it's very important to do. I got to tell you, it's been hard. I mean, since March 1st, it's just been constant. And as a national association, where with the COVID issue, there's always a hot spot of some kind or a surge. You can never rest. So it has been very difficult. Fortunately, have a very supportive wife, she's there to make sure that everything gets taken care of. But I'd be lying to you if I said it was easy. In general, when you're in these kinds of roles, and Eric would say the same thing, being the head of a large enterprise where the buck stops with you, and you're in charge of the safety of a lot of people. That's part of the privilege of having the leadership role.
I got a question for you. I'm the president of the Entrepreneurship Club here at Cortland and the vice president of the Investment Club. And so, looking as the whole world is changing and how millennials like the telehealth and the TDoc and things like that, is there one company that's making COVID vaccines that would stick out to you and you would kind of stick through with if you were in my shoes?
In terms of investing in it?
Yeah.
Well, it's interesting you say that, because we have this scorecard, and if Professor, if you want to send me to this, I can send it to you. We have the scorecard of all the different vaccines that are under exploration and which companies and where they are in the process and the nature of them. It's still in play. We don't know which ones are going to ultimately make it yet. And, we're not a scientific organization. We can only take the advice from our clinical experts. So it's too early to say, and I'm certainly not an expert to, say that one may be better than the other. I'd be glad to send you that, and you could, have that information.
Sure, thank you.
Just email me at rpollack@aha.org, rpollack@aha.org, and I'll send anyone that wants to see that.
Now that's two clubs that we did not have.
Thank you for that question, Carter.
And by the way, anybody that wants to email me on any follow-up questions, I'm happy to handle them and or send you some materials.
Are there any other questions from the audience?
Well, Rick, whether there is or not, I have to tell you, this has been fascinating, and I agree with Rob. You make me very proud to call you a Cortland grad. So thank you for doing this. I know that the faculty would love to get you up here, but we'll do it when it's a safe period.
Sounds good. Well, thank you for having me. I carry Cortland with me wherever I go.
Thank you. Thank you. I'll leave it up to others, but it's been really an honor to listen to all this. It is really fascinating.
Thank you.
So, Rob has a question. Go ahead, Rob.
You're on mute.
You're muted.
You're still muted.
You're still muted.
Yeah, it's because I don't have anybody under 60 here in my house, and that's why. No, I gotta run. Actually, we have an issue that's coming up with outdoor dining, and I gotta get on a call with the city council. So it was truly a pleasure listening to this. Rick is a wonderful, we got to get him on the foundation board. Don't you think, Eric?
Happy to serve.
Take care, buddy.
So, Rick, we talked about there being a lot to unpack in 2020, right? Any singular event would have a lot of healthcare delivery outcomes, changing that aspect of healthcare delivery, you know, from the pandemic, natural disasters. We have the fires out west. So we have a hurricane about to hit Louisiana. And we talked about the systemic and structural racism as well. So parting words, where do we go from here? Things we should focus on. What would you like to leave us with?
What I would like to leave with you is vote. Regardless of what your preferences, is really important for our country. It's really important for democracy that people vote and vote early, and make sure that your voice is heard. Elections matter, and I think we know that this is about as important an election as we've ever faced in this country.
Okay, so thank you. So we've come to our end of our Executive in Residence event, our first virtual event. And this was a joint event between the Political Science, Economics, and Health departments. So I would like to extend a thank you to the chairs, Dr. Mary McGuire, Dr. Flavia Dantas, and Dr. Jill Murphy for their collaborative efforts and support. And also to President Bitterbaum for his opening remarks and kicking off this event. To Rick Pollack's team, especially Darlene Vanderbush and Jennifer Holland, who were in communication with the College Foundation and alumni engagement to see this to fruition. And of course, thank you so much, Rick. This was definitely an honor to join you in this conversation tonight. So it truly means a lot when alumni, especially one who happens to be the CEO and president of the AHA, shares their knowledge and insights with our faculty, but especially our students. So thank you for speaking with us tonight. And to our audience, thank you for logging on in the comfort of your homes or offices for this virtual event. So have a good night, everyone. Be safe and thank you.
Thanks.
And Vern, thank you for all the time you put into this as well. It's recognized. Good night, everyone. And Rick, thank you so much. It was great.
Thank you so much.
Being with you.
Yeah.
Good night.
Thank you.
Hey, Vern.
Hi, Mike. Is it possible to get a participation list?
Oh,
well, you know what? I think I've used WebEx before where it's sent afterwards in your preferences. I can talk to you about that. Of course, I saw some of my students, but they did have an assignment either to ask a question or write a reflection on. So some I did see in terms of, Carter, Maddie. I saw a couple of them, but I know I may have missed some. So
Carter's your student?
Yeah, Carter is in my HIV course.
Okay. I'm a volunteer wrestling coach, so I know Carter through that. So I was happy to see him on. And then when he asked the question, I'm like, good for him to step in and.
Because I did tell my students, like, this is an event that if I was a student during my time, and if you ask a question, and we opened it to questions, and I'll send Rob a message as well, because, seeing their friendship on camera, Maddie is still on. Seeing their friendship on camera, I think helped the conversation. Helps the conversation a lot. And thank you with my dad, because I think eventually I try to text my sister to say, can you call daddy and just, so one sister, she has two little ones. She didn't even sign on because she just knew with her little ones, it may go crazy. So I text her and I'm like, can you tell? And she was like, she's like, can the host just mute him? I was like, he does, but every time he mutes, daddy unmutes. So she was like, oh my. So I know for me personally, initially I was skeptical of sending it to my parents because of that, but I know for them, it's, it's a big deal.
No, it was awesome. It was great to see him on.
So I know they were trying, and my mom is a little bit more savvy, but she had a church meeting. So and she was like, I'm going to set up the computer for your dad so that he can. So I literally texted her and was like, I know you're in a meeting. She's like, I told him to leave it, but he's not paying me. So that's why sometimes I'm like, I jump to the next question without even closing because it was like, part of me was not listening to what Rick said. So as much as I plan on having transitions based on what he said, it was like, I was just trying to text him to be like, can y'all just, relax? So yeah.
Yeah, no
So,
problem.
thank you so much for organizing this. I really think it went well. I was a little nervous about the virtual aspect. I was hoping more of my students did sign on, but at the same time, I thought the conversation.
Matt,
Still Barb's question. I thought the conversation went well.
I thought it was fantastic. You did a phenomenal job. Thank you very much for moderating this and taking the time to do it. I've recorded this. I'll send the recording.
Oh, thank you. My mom would like to see, because that's what she asked me, and I was like, Mommy, they're not gonna record this because it's, just for the conversation and the students, because that's the first thing she said.